Dysarthria and Multiple Sclerosis, Research, Assessment, and Treatment by Sarah M. Porch. The following is a consideration of the presentation of dysarthria in individuals with multiple sclerosis. The literature review will place the research which identified speech disturbances in MS in a historical context. It will then give an overview of how this context informs future investigations into the prevalence and characteristics of the dysarthrias in MS. A synopsis of recent research into the relationships of cognitive linguistic aspects of communication and speech is presented. The second part of the presentation examines the clinical implications of dysarthria in patients with MS, including differential diagnosis, assessment, and treatment. Introduction. The inflammatory processes in the central nervous system in MS can result in dysarthria. Dysarthria literally translates to abnormal articulation. However, Duffy defines it as a collective name for the neurological speech disorders resulting from abnormalities in the strength, speed, range, steadiness, tone, or accuracy of movements required for the control of respiratory, phonatory, resonatory, articulatory, and prosodic aspects of speech production. Dysarthria is classified into types based on the perceptual characteristics caused by the changes in function of the systems involved in speech. The manifestation of speech disturbances were associated with MS from the time of its initial identification in 1868. Literature review, a historical context. Jean-Martin Charcot was the first to diagnose MS in a living patient in 1868. He was known as the father of neurology. He formulated a triad for the diagnosis of MS, including nystagmus, intention tremor, and scanning speech. Scanning speech is defined as prolonged phonation of each word with slow and slurred articulation of the individual consonant sounds with abnormality of pitch and inflection. Pharmakides and Boone in 1960 indicated the case histories of 82 patients with MS had a combination of 5 contributing factors to their dysarthria. They were nasal voice quality, weak phonation of voice and poor respiration cycle, changes in pitch, slow rate, intellectual deterioration, and emotional lability. The conclusion of their study was that intelligibility gains due to increased rate of speech and louder phonation occurred in 85% of participants. Darley, Brown, and Goldstein authored the first comprehensive study of the presentation of dysarthria in patients with MS. Their sample included 65 males and 103 females ranging in age from 17 to 73. 83% presented with symptoms of the disease for at least 2 years. 31% had symptoms for 10 years or more. 62% of the total presented persistent symptoms judged to have been permanent symptoms for at least 2 years. Speech deviations were then assessed across 9 dimensions. The results were that 28% demonstrated minimal speech disturbances and 13% demonstrated more severe disturbances. The conclusions were that dysarthria is not almost constant in patients with MS and that scanning speech was not found to be a salient characteristic. Severity was related to neurologic involvement, not age, and speech deviations were not solely related to cerebellar involvement as previous studies indicated. Additionally, oral reading and diaticokinetic rate demonstrated the effect of MS on motor speech. Literature review, recent perspectives. Merson and Rolnick concluded that dysarthria occurs in 40% of all patients with MS. Findings of speech symptoms occurrence was similar to that of Darley and colleagues. They found intensity, quality, and articulation and intonation to be the highest occurring. They also identified the disturbances as a mixed spastic ataxic dysarthria. Research of Hartlius and colleagues supports a prevalence rate of 40 to 50%. Analysis of speech demonstrated three distinctive bands of instability in fast Fourier transforms. However, a more recent cohort study found prevalence to be 62% based on clinical dysarthria tests, 20% based on neurological examination alone, 51% based on the combination of the two assessment measures. This suggests that multidimensional assessment is appropriate in diagnosis. Hartlius, Theodorus, Cahill, and Lilvik conducted a cross-linguistic analysis of dysarthria in Swedish and Australian speakers with 133 participants in 2003. They used a 33-point protocol. They examined 6 deviant features: harsh voice, imprecise articulation, impaired stress patterns, rate, breath support, and pitch variations. They found variation in rankings and frequencies, but general agreement with Darley's list of the 7 most prevalent deviant speech features in patients with MS. New directions in research. A body of research is developing linking the cognitive linguistic status of the patient with speech intelligibility. McKenzie and Green in 2009 found the relationship between performance on standardized cognitive measures and the assessment of intelligibility in dysarthric speech. Finaudy and colleagues in 2013 examined speech timing during 2 tasks, oral reading and narration. They found that previous assumptions regarding an effect of cognitive load on speech require further research. And Rogers et al. In 2013 examined cognitive predictors of speech and articulation rate in patients with MS with standardized cognitive and intelligibility measures, finding no significant difference in simple reading versus self-generated speech, indicating further research is warranted. ASHA is currently constructing an evidence map compiling best practices in the treatment of speech-language presentations in patients with MS. Clinical implications. Due to its high prevalence in patients with MS, dysarthria is used in differential diagnosis of the disease. Differential diagnosis of types of dysarthria are based on extent and location of lesions. Ataxic is due to bilateral lesions of the corticobulbar tracts. Spastic is due to bilateral or generalized lesion of the cerebellum. Mixed is due to bilateral generalized lesions of multiple areas in the cerebral white matter, brainstem, cerebellum, and/or spinal cord. Mixed dysarthria is the most common type due to the complex involvement of neurological systems in MS. Differential diagnosis of the type of dysarthria is crucial to the treatment and pharmacological management planning. This chart details the speech and voice signs of both spastic and ataxic dysarthria, which are the less common presentations of dysarthria in MS. This chart details mixed dysarthria, which is the more common presentation of dysarthria in MS. Speech and voice signs include impaired loudness control, harsh or hypernasal voice quality, impaired articulation, impaired emphasis, and impaired pitch control. Related neuromuscular and physical signs are any combination of the spastic and ataxic features as mentioned in this chart above. Clinical implications for assessment. According to Johnson and Jacobson, a comprehensive motor speech examination should include detailed medical and social history, assessment of oral motor function during non-speech tasks, which includes structure and function of articulators, respiratory support and control for speech, laryngeal function for loudness, pitch, and voice quality, assessing the strength, symmetry, range, tone, steadiness, speed, and accuracy. It should also include quantification of intelligibility using a tool like the assessment of intelligibility of dysarthric speech. Auditory perceptual speech analysis of characteristics and intelligibility include simplified speech tasks, including alternating motion rate, sequential motion rate, and vowel prolongation. Citation tasks, including repetitions of sounds, syllables, words, and sentences, and production of automatic speech, and also language formulation tasks, including conversation, narrative discourse, and oral reading. Other assessment dimensions include measures of vocal quality, measures of communication effectiveness, acoustic and physiologic measures, and also standardized measures for dysarthria, which include the French Dysarthria Assessment, second edition. Also, there are non-standardized formal measures available as well. Clinical implications for treatment. Spastic ataxic dysarthria treatment includes pharmacological interventions and rehabilitative techniques. Perceptual analysis is still the standard for treatment planning. 2 out of 3 adults with central nervous system disease like MS who sought treatment due to decreased intelligibility were found to progress to a level of increased communication, independence, and were intelligible to all listeners following intervention, according to ASHA. Speech problems can fluctuate with exacerbation and remission, which can shape treatment. And candidacy for treatment includes severity and progression of the disease, severity and complexity of speech problems, and cognitive and emotional status, and also an engaged communication partner. Treatment for reduced loudness can include medications for spasticity and fatigue, postural adjustments, breath support and control exercises, diaphragmatic breathing technique, spirometer for inspiration, using a recording device to monitor loudness, and working on phrasing, and use of a voice amplifier to monitor loudness. Treatment for monoloudness can include taping passages to read along with to variable loudnesses and trying to carry over this skill from reading to conversation. Excess and variable loudness can include pharmacological treatment for tremor and ataxia, posture and trunk stabilization and head control, and relaxation techniques, including EMG and biofeedback for smooth respiration and easy onset. Treatments for vocal quality include medications for harsh and strained vocal quality, also relaxation techniques with biofeedback, open mouth and yawn sigh approaches to speech, taping speech, and computer software that provides feedback like Visipitch, and carryover of these skills into words, sentences, and conversations. Treatment for hypernasality can include soft palate exercises, increased breath support, articulation drills, open mouth approaches to direct more oral than nasal flow, slowed rate of speech to allow extra time for velar movement, tape recording to identify and match target voice quality, and practice in words, sentences, and conversation. Treatment for vocal tremor includes medications, evaluation for Botox treatment, posture and trunk stabilization, relaxation techniques and biofeedback, recording speech, and practice. Treatment for imprecise articulation or irregular articulatory breakdown includes medication for spasticity, tremor, ataxia, and fatigue, oral exercises to improve range of motion, strength, speed, and coordination, enhancement of breath support and respiratory control, relaxation techniques and biofeedback, tone and movement of specific articulators and the timing of respiration, phonation, and articulation, identification of error patterns, practice of behavioral compensations like slower rate, over-articulation, and phrasing, use of pacing boards, practicing new skills during reading aloud and conversations, training of dysarthric to solicit feedback, and training of communication partners, and in some cases, use of AAC. For prosody, treatment can include working on stress patterns, use of a tape recorder to monitor your speech, practice of emphasis on most important words, reading aloud, utilizing underlined keywords, use of a speech lab with computer software to visualize and max targeted variations, and controlling speech rate by interjecting pauses in logical places. Psychosocial considerations. The reduced ability to functionally communicate can lead to social isolation and depression. Further, slurred speech from impaired articulation can be misinterpreted as drunkenness or a lack of intelligence. Patterns of remission and exacerbation are significant factors in the patient's sense of loss of control. And patient and caregiver counseling and education are crucial aspects of the management of the psychosocial aspects of MS. Current models which put patient-centered care first drive the importance of the psychosocial aspects of the diagnosis and the treatment of dysarthria in MS. Summary. While speech disturbances have been part of the discussions surrounding MS since the time of Charcot, changes in the identification of the characteristics and treatment of dysarthria continue to emerge with new research. New directions, including the interplay of cognitive linguistic status and speech intelligibility, have promised for shaping future treatment approaches. As the body of research grows, not only are treatment options expanded, but also the understanding of the clinical presentation will deepen. Additionally, rapidly evolving diagnostic advancements and pharmacological options will impact the practice of the SLP with patients with MS.